Welcome back to the Band-Aid Man OC. Today we're going to be going over Chapter 35 from the 14th edition of Emergency Care. Chapter 35 is all about environmental emergencies. So if you're following along with the book or with the slides from your own instructor, great. If you're one of my students, just go ahead and follow along with the slideshow. But we're going to be going slide by slide and explaining what we're talking about. So the topics for this particular chapter are exposure to cold, exposure to heat, water-related and altitude-related emergencies, as well as bites and stings. Now, if you are using a different textbook and you're like, oh, Johnson, this is like so much shorter than my book, your book might actually go into more detail than this particular book or chapter does. And if you are looking at this from the perspective of someone that is going through an outdoor survival or emergency course, this is certainly going to be much less the material that you would need to know. However, this material does cover what the National Registry of Emergency Medical Technicians considers to be enough to get through the test. So if that's what you're looking to do, pass national, you're in the right spot. So let's go ahead and let's get started. First, we have exposure to cold. Exposure to cold can truly occur in any setting, whether it be wilderness, rural, urban, suburban, whatever the case may be. It is simply that exposure and really overexposure to cold and the elements. If your patient has other pre-existing conditions, whether they be illnesses or injury, that can certainly make this emergency much worse for them. We can also find that the patients that are under the influence of drugs or alcohol might be at higher risk for further emergency if they are overexposed to the cold. And just for a little, heads up, the same can be said about heat. So there are five ways that the body can lose heat. These are conduction, convection, radiation, evaporation, and finally through exhalation. So let's talk about each of those in depth. Conduction is where we have direct contact. If I take my hand and I place it right here on this window and the window is cold, my hand will over time become colder. That's through conduction. It's just as it sounds, direct contact. If any of you have a conduction pan or some type of conduction type cooking device, you know that the only way that it will get hot is through direct contact. Next is convection. Convection is where we use air or water to carry heat away or towards some type of object. Convection can be seen in an air fryer. So if you go into your kitchen and you have an air fryer and you're thinking, oh man, I want to heat something up, I want to make something quick, it's using a process known as convection, where air is used to carry heat directly towards the thing that you're trying to cook. In this case, because we're talking about cold related emergencies, this is where we get wind chill. And everyone knows that you got those people that say, oh boy, it sure is cold, but man, with that wind, it really makes it colder. There's something to be said about that. That truly does make an environment colder. So wind chill is a real thing. It's not just something that old people like to bring up. The next is radiation. This is where we have heat or cold that's picked up by surrounding air or water and then carried away. Now that is going to be different than convection because convection is going to require actual, contact, whereas radiation is getting ambient cold or ambient heat pulled in from all of these different sources, whether it be water or from air. Next, we have evaporation. This occurs when your body sweats and then we begin to allow that fluid to rise off the skin. The reason that your body is sweating is so that we can cool it down. And when you are perspiring, aka sweating, your body's trying to cool itself. This process can also be seen if we use something that evaporates quickly, such as rubbing alcohol. So if you take rubbing alcohol, place it on the skin, you might notice that your skin temperature feels to the touch or feels internally like it's colder. It's because rapid evaporation is causing rapid cooling of that site. Finally, we have respiration. A respiration is something that you've already been exposed to in this course, but it is the process of exhaling and inhaling. And as we're exhaling and inhaling, we are both losing and gaining heat depending on the ambient temperature outside. So if we're looking at our patient and we're thinking that a heat or cold related emergency is occurring, we have to consider any of these five conditions as being the cause for their heat related emergency. If the patient is experiencing one of these heat related or cold weather related or temperature related emergencies, we need to move quickly so that we can stop the process from continuing to occur. This slide shows just a quick heads up on how all these processes work. So let's take a look at each of them in the order that we've already talked about. Conduction. In this patient who's sitting on the ground, it looks like a gentleman that was in an outdoor environment, hiking perhaps, based on the shoes that he's got there. They look like some of the newer types of hiking shoes, very, very light hiking shoes. We have body heat where we're losing it due to direct contact. So this gentleman is losing that directly to the ground or the rocks that are surrounding it. The next is through convection. This gentleman is currently losing heat because the surrounding air around him is colder than his ambient body temperature. And if you think about what your ambient body temperature is, that's going to be between 96 at the low end to 99, just below 100 degrees at the high end. The next that we've talked about from this slideshow is going to be through radiation, where the body is losing, they're losing temperature based on the surrounding atmosphere, but that's not through something that is directly touching them. So even though we have air that's passing over the patient that's colder, that's how we're going to be relieving it, but it's not through that direct process. It's because the ambient air is so cold. Next, we have evaporation, where the patient was at one point perspiring, they were sweating. That's allowing heat to escape their body and then turns into the air and evaporates. And then finally, we have through respiration, which is breathing in and out. So now that we've got all those out of the way, we're going to talk about some generalized concepts of cold-related emergencies. In hypothermia, which is something that most people are familiar with, at least in relation to terminology, we have an exposure that's reducing body heat, and the body itself isn't able to go through the process to maintain their proper core temperature. If we leave hypothermia untreated, it will lead to death, plain and simple. It will lead to the patient dying. So we need to make sure that we are recognizing and treating for it as early as humanly possible. Some predisposing factors that might actually lead the patient to the possibility of developing hypothermia are actually pretty lengthy. We'll start with these, and then we've got another slide that shows some more. The first would be shock, which is a process that we've talked about in other chapters, but remember that shock is, generally speaking, a lack of perfusion of the tissues. So because of that lack of perfusion, we're going to have difficulty, if not the impossibility, of maintaining body temperature, which will lead to hypothermia. The next would be injuries, infection, or immobility, the 3 I's. So if we have a patient that's already injured, their body's already trying to fight a battle, which is trying to repair that injury. The same can be said about infection, where it's actively fighting off something that the body knows is bad for it. And then finally, immobility. Immobility relates to how mobile they are. If they are unable to move, they will have a much harder time generating heat, which will in turn lead to hypothermia. The next is diabetes with hypoglycemia, because hypoglycemia is going to lead the body to a very low state of available, usable glucose in the body. The body is going to start using whatever it can to go through its normal day-to-day. And the loss of body temperature is one of the side effects of prolonged hypoglycemia. The next is drugs and alcohol use. Aside from the drugs that we've already talked about in other chapters, we have to remember that drugs and alcohol have different effects on the body. Drugs that do not have a stimulating effect, meaning they are not a stimulant, such as cocaine, crystal meth, MDMA, things like that have a stimulating effect on the central nervous system, will lead to hypothermia, generally speaking. So when we're looking at opiates or other narcotics, and then of course alcohol, will have loss of body heat. And as a quick note, for those of you that are of age that have actually consumed alcohol before, you might be thinking, Johnson, I've had alcohol before. I felt like I was very hot. Your body is using that alcohol, and it's causing the blood vessels to expand very rapidly. It's also causing your body to experience flushing, where the capillaries are getting a rush of blood all the way to the very surface of the skin. So even though you're feeling hotter, you're actually losing body temperature because the body is losing the ability to regulate some of those things. So just as a little heads up, if you are the kind of person that likes to go ski or snowboard or spend time in the snow or up in the mountains, and you're thinking, I'll have a little nip of the old brown stuff to warm up, terrible idea. If you're under the age of 21, ignore everything that I just said. Next, and we already talked about alcohol ingestion, so this is a bit of a misnomer. No reason to continue talking about it. We have underlying illness. So in the patients that have underlying illness, we have already a body that's trying to fight off certain infections or certain things that are, adversely affecting it. So the body's already in a state of relative panic. We also have the body trying to create the ability to get over these things, whether it be an infection or a general underlying illness that's more long-term. The body is at a disadvantage. And since it's at a disadvantage, we're not going to have the same ability to keep the body warm, which does take a lot of energy. The next would be overdose or poisoning. We've already spoken a bit about overdose in the term of drugs, but remember that not all overdoses are based on illicit substances. It could also be a medication that was prescribed by a doctor and then taken improperly or to a much larger amount than was prescribed. Poisoning, that's a bit different because we're looking at something that the body is not supposed to ingest, whether that be bleach or ammonia or weed killer, something to that degree. Your body's fighting something that's also fighting it. When your body is working against something that wants to make it unhealthy, it's going to struggle doing the things that it does without your input at all. Those things might include things like breathing, pretty important, the regulation of your heart rate, which is also very important, but also things that are less in the top of the mind, like heat or cold regulation in the body. The next would be major trauma, and this goes back to injuries. So think the injuries that we can already kind of figure out in our minds, the broken bones, the punctures or penetrating wounds, all that DCAT BTLS stuff that we've already discussed. And I want you to now think about the kind of major trauma that affects more than one body system or multi-system trauma, like we talked about in chapter 30. The next would be outdoor resuscitation. By the nature of where the resuscitation is occurring, unless we are in an extremely hot environment over 98 degrees, the body will eventually become hypothermic based on the fact that it cannot regulate its own temperature. Therefore, outdoor resuscitation, or as I like to say, resuscitation, will be something that we need to actively work towards to bring the body up to a normal temperature before we can make the determination that the patient will not be coming back. And then finally, we have decreased ambient temperature, which is a big fancy way of saying it's cold out there. Now, a couple notes on our very old patients and on our very young patients. On the very old, the effects of temperature change are immediate. And this is something that most of you would already know. You go over to grandma and grandpa's house, you go see Nana, and you walk in, it's a beautiful day, it's 85 degrees outside, the sun is shining, the birds are chirping, and you go inside, and Nana's got the fireplace running, and you're trying to figure out, why are you so cold all the time? It's because older adults lack some of the things that we have in our body throughout the majority of our lives to maintain ambient temperature. Their bodies are shutting down, and we're talking about our geriatric population over the age of 60, 70, 80, think in that range. These people are going to have a difficult time regulating temperature because their bodies are largely shutting down. Also, something that's important to note, if you live in a cold area, I teach in Southern California, so obviously, I mean, you can see outside, it's beautiful, it's sunny, it's really not all that cold. But in some of these other areas, we have patients that live on fixed incomes, that live in, areas where they can't necessarily make the heat in their home high enough to be comfortable. And if you are from one of these areas, you're probably thinking to yourself, yep, I remember when Dad used to make me keep the thermostat at 68, whereas everybody here in Southern California is thinking, oh man, that sounds like a perfect temperature to have the AC running at. When you're dealing with individuals that are low income, no income, fixed income, they may need to make the determination, do I buy my medications? Do I buy my food? Do I buy my heat? Or do I buy which two of the three do I buy? Because they may not be able to afford all of them. So it's important to not only make note of the implications when it comes to patient care, but also the implications as it relates to social care. These people that are on fixed incomes that cannot heat their own homes, we need to make sure that we make the proper referral to social services or the proper authorities in our area that actually deal with this. So something important to note. On the pediatric side of things, so on the opposite side of the lifespan development scale, we've got the little ones. The reason that these little ones are very, very, inefficient in the way that they regulate body temperature is because they have a very odd set of, collections when it comes to their total body mass compared to their total body fat and body surface area. So with these large surface areas and very little body fat, they're going to struggle. They're going to have a very difficult time with maintaining body heat. And we have to make sure that we are very aware of the signs and symptoms and hypothermia for all patients, but especially in the very old and the very young. Looking for things such as peripheral cyanosis, so cyanosis of the fingers and toes, numbness or tingling in the fingers and toes, and some of the other areas of the body that would be the early onset or the early identifiers of a cold-related emergency, such as the lips, the ears, and areas of the face being pale or becoming blue. Another thing to make absolute mention of is that in general, humans will do something very similar across the board when they're cold. They will try to keep a little bit of warmth. They'll use their arms and they'll cover up, but they'll also do something that we are all very unable to do at very low temperatures, which is shiver. Shivering is the body trying to warm itself up through basic movement. Just like we mentioned earlier, immobilization, not being able to move, can actually lead to hypothermia. So we have to understand that when the body is trying to warm itself up, it's going to cause it to shiver. Very, very young children, especially infants, are very they're very basic in the way that they respond to things. So your youngest patients might not shiver at all. I've got a 3-month-old at home. We have to be very aware of what he's doing and what the temperature is around him, because he simply lacks the ability to tell us, hey, Dad, I'm cold. So just a couple quick notes on our geriatric and pediatric populations. Let's move on to our assessment. While we're looking at our patient and we're considering hypothermia as being a cause or the general aspect of their emergency, we have to look for these very simple early signs: shivering, numbness, any type of reduced sensation or interpretation of touch, posture that seems stiff or rigid. And I think a lot of you are thinking to yourself, oh man, the last time that I was really cold, I had a lot of these things. As we go down through more of these, we're looking at later stages such as drowsiness, rapid breathing, or slower absent breathing, and especially slower absent pulse in prolonged cases. Loss of motor coordination, stiffness in the joints or muscles that feel rigid or unusable, decreased or unconsciousness, so decreased level of consciousness or unconsciousness. Abdominal temperature, this is a big one. Feeling around the belly. This should normally be pretty warm for any number of our patients because we have such a collection of abdominal organs that need to maintain a specific temperature. If you feel their belly and it's cold to the touch, that's a very late sign. It can indicate to us, hey, this person is no longer regulating their temperature. And then, of course, because it wouldn't be normal if we went completely out of order, red skin being an early sign, pale or cyanotic skin would be a late sign. So red skin early, pale or cyanotic skin late. So in our assessment, we're looking for the things that most of us have experienced at some point in our lives. I feel cold, I look like this. I feel cold, I feel like this. So put yourself in the shoes of the patient, which is something we can't always do, and try to consider how they're presenting to you and say, aha, I would also feel that way if I was extremely cold. Moving forward, we understand that with very cold patients, we would like to make them warm or warmer patients. We have two processes that we can use to warm a patient, whether it be systemically, the whole body, or if we're going to rewarm a specific part. Passive and active rewarming are something that a lot of people think, oh yeah, we'll just throw a blanket on them and then just shove them into a hot tub. Not quite the right way to go. So let's talk about passive versus active, and then we'll talk about a couple different strategies. First, passive rewarming is where we are going to cover the patient with dry materials. They don't need to be warm materials. It can be a blanket that's been in the back of the ambulance, but something that is dry. And we also need to remove any wet clothing because wet clothing is removing heat due to conduction. Next, we have active rewarming. This is where we're applying an active heat source, whether it be a hot pack, heaters, or warm or, nearly hot water. And I'm putting air quotes around that because, of course, you could say, well, technically 94 degrees is hot. Yes, that's fine. But I don't want you to get into boiling water, obviously, and definitely not the kind of water that we would expect to be coming out of a spigot or a spout for a bath or a shower, something that is of that high temperature. So let's look at appropriate rewarming techniques for these patients. First and foremost, remove wet clothing. It's got to come off. I understand that a lot of patients are not going to necessarily be super stoked about this. If we can give them something to wrap around themselves so they can go and change, that's fine. But if your patient is unconscious, unresponsive, or unable to do it themselves, we're going to have to do it for them. Next, we want to apply active rewarming, such as using the heater in the back of the ambulance and using things like heat packs to actively rewarm during transport, so long as it's not going to cause localized damage. We need to look for the signs of shock, which remember are signs of hypoperfusion. And if they are showing signs of shock or hypoperfusion, we need to be able to recognize and treat that effectively. One of the things that I want everyone to understand is that although patients in shock will likely require oxygenation, we don't give oxygen to just anybody, not only for the fact that it's a drug, but because we have further training that will let us know, hey, oxygen would be an appropriate treatment for this patient. So use your brain, look at the signs and symptoms and treat based on the signs and symptoms. And instead of just saying, hey, if they want to go O's, they got to get the O's. That's a terrible way to do things. That's also a terrible rhyme. Don't use that. If your patient is conscious, has a gag reflex, and is responding to questions appropriately, they're alert, we can consider giving them warm liquids as long as they take them in at a slow rate. Drinking water rapidly or any other warm liquid, and we're not going to be giving them a hot toddy, which for those of you over 21 is alcohol. For those of you under 21, it's a soda. It's a hot soda. We're not going to give them any of that. Okay, we're not going to be giving patients any kind of warm liquids other than water, or if you have a local protocol that says something else, you can use that, but no alcohols or anything like that. If your patient is showing these signs and symptoms on the average patient, you'll likely need to transport them to the emergency room, not only for further rewarming, but also for monitoring. We want to make sure that this patient isn't going to fall back into the case that put them into a specific position where they became hypothermic in the first place. So we need to be very, very cautious about the way that we do this. This is a picture that shows an example of active rewarming of a frozen part, because as I said before, we can use passive and active rewarming as a systemic response or systemic treatment, or we can use it as a local being hands, feet, things like that. If we throw a patient into a bathtub, is that local rewarming? No, that's systemic rewarming. Also, we don't do that because the last time I checked, ambulances don't come with a hot tub attached. These aren't limos. And as I've said in other videos, we don't have a dry bar in the back or a wet bar. So, got to make sure that you have the right stuff. All the cases that we talked about so far have been very mild, very basic cases of hypothermia. In extreme hypothermia, which is a not absolute term, that's just a generalized term, we have a patient that is not showing very many signs of life. They are unconscious, their vital signs are extremely low or absent, and this patient is truly having a medical emergency. Their heart rate can slow as low as 10, if not all the way down to 0, and they are very cold to the touch. These patients are the ones that you feel and you go, ooh, it's cold. If they are pulseless, we're going to start CPR. We want to make sure that our AED is in place, and of course our BBM. So when it says start CPR with the AED, it's not any different than any other time that we would apply CPR as a treatment. But we need to make sure that CPR is initiated as soon as possible. However, if they have a pulse, we're going to care for them as if they were any other patient with a pulse that was unresponsive or altered to some degree. And we're going to try to treat the underlying cause, which in this case is what everyone listening to this video, right, their temperature. So treat their temperature. They put this quote down at the bottom in bold, and I tend to, make sure that my students who are sitting out here and taking a test and looking at me all annoyed, I tell them the same thing. You're not dead until you're warm and dead. What this truly means is that we will not stop resuscitative measures on an outdoor cardiac arrest event or a hypothermic patient in cardiac arrest until they are warm and dead, because for a lot of these patients, being that hypothermic can actually preserve brain tissue. So it's a very important thing to remember. You're not dead until you're warm and dead. Aha. Moving on. If your patient that you responded to was unresponsive or they're altered and they are dealing with a hypothermic emergency, we want to make sure that their airway is open, that they are breathing appropriately, and that we are checking for their circulatory efforts, so ABCs. And as my students would know, we're going to check in this unconscious or unresponsive patient, CABs, circulation, airway, breathing first. Provide high flow O2, and if possible, pass it through a warm water humidifier, which is something that here in Southern California we don't have, but in other parts of the country where these types of emergencies are absolutely part of the day-to-day, they're going to have them available. So use it if your service has it. We also want to use passive rewarming techniques such as warming blankets. And since we're talking about it, think to yourself, would warm water humidifiers with oxygen be considered an active or passive technique of rewarming? I think that if you're using critical thinking, you have to understand this is an external source. Therefore, it is active rewarming. Wrapping the patient in blankets, making sure that they are dry would be passive. And then, of course, we need to transport this patient right away, as quickly as possible. Moving into the less extreme, but certainly still important to discuss injuries, we have local cold injuries and frostbite. This most commonly affects the ears, nose, face, hands, fingers, feet, and toes. So all the stuff on the periphery. So the fingers and toes, and then stuff that juts out from your face. So nose, ears, your face, things that you don't want to have cold for a long period of time. Because cold restricts blood flow, which will be important later. So remember that cold equals restricted blood flow. We may have localized injury. This comes from freezing of tissues, and in these tissues, we might actually find the formation of ice crystals, which if we rewarm too quickly can actually explode and cause localized tissue damage and, of course, tissue death. So we have two levels. We've got early, known as superficial, which may be known by those of you that live in these colder areas as frost nip. This is where, you know, the tips of your nose, your ears, your fingers and toes, they're really red. They're uncomfortable. They might be slightly numb. You might find that there's localized numbness for, you know, the better part of, you know, 5, 10, 15, 20, 30 minutes even. We need to remove this patient from the cold and then cover them up and use passive rewarming as a technique. In late or deep, we have what's known as frostbite. This patient requires oxygen, and we need to make sure that we cover their frostbitten part and handle as gently as possible. Now, in your mind, you might be thinking, oh, this is it. This is where we're going to use active rewarming. Absolutely not. Remember, tissues might freeze and might form ice crystals. So we rewarm it too fast, those ice crystals will expand, and that can cause the localized damage and or death of the tissue. It's very important that you make sure that we rewarm this as slowly as possible. It's just like when you're making turkey or you're making that Thanksgiving turkey, right? You can't thaw it in the course of a couple of hours. You have to thaw it over days, because if we thaw it too quickly, we can actually damage the turkey itself, and then it won't taste very good, and it might actually be dangerous for us to consume. Here's a picture of a localized frostbite injury, or I'm sorry, a localized cold injury. And at this stage, it may be frostbite. Based on its appearance, it looks like it certainly was frostbite. And you can see some of the lines that show that there was an expansion of this tissue, which leads me to believe that this was something that required some type of immediate transport. But this is going to be a long-term injury for the patient to recover from. Active rewarming of frozen parts. I want to make sure that we're all clear here. This is not recommended because of the high chance of permanent injuries. If your local protocols recommend it, then you would need to follow what medical direction is instructing you to do. And we should definitely make sure that we follow our local protocols, or SOPs, the standard operating procedures, or your scope of practice, to using local rewarming. To do rewarming in this process, we're going to use warm water, not hot, but warm water. We're going to have the patient immerse the part into that warm water, and we're going to need to ensure that they do not have that part touch the sides or bottom of the device that's holding, the container that's holding all of that fluid. The reason is because it can actually become adhered to the side or to the bottom, which will lead the part to basically ripping all the skin off when we do remove it, which is, I like to call bad. So we're going to heat the water here between 100 to 105 degrees Fahrenheit. Going to fill the container, and then as we're filling the container, this is an excellent time to remove constrictive clothing, jewelry, band straps, anything that will get caught as the skin and as the tissue expands. And then we're going to immerse the frozen part with a reminder: do not touch the sides or bottom. Continuously stirring the water will make sure that we are not warming in a way that is disproportionately affecting one part that's maybe lower in the bucket or container. And make sure that if we are doing this stirring, that we're continuously assessing the part to make sure that we're not missing any of the rewarming that's occurring. We need to make sure that the patient is at rest during this entire process, because if they are not at rest, they can incidentally touch the side. It might delay their recovery, and we might actually find that the injury becomes worse, not better. We also want to make sure that the patient is being actively rewarmed, because for the most part, we're not going to have a patient with one hand that was frozen, but the rest of them was, hey, okay, everything's fine. So make sure that we're maintaining the patient's warmth and not just rewarming that one part. We'll need to continue monitoring the patient, continue taking vitals, and then, of course, do not allow the limb to refreeze. I'm going to say that this is under yeah and or duh. So don't let your patient get refrozen. Don't do active rewarming and then say, all right, back to the bus bench with you, and then send your transient patient back to sleeping on the bus bench. And of course, transport the elevated limb as soon as possible. And if we have stopped the active rewarming process, have them elevate the extremity to the degree that is most comfortable for them. Now, as we move on to exposure to heat-related emergencies, which in contrast to cold will be the diametric opposite, we have to consider the environment the patient is in, the ambient temperature, and their exposure risk. So as cold affects the body, heat also, disproportionately affects the body in large amounts. So we need to understand what effects we're looking for. We don't have the ability as humans to regulate on demand what we need, whether it be heat or cold, but for the most part, our body will do it for us to, within certain parameters. We also have the ability to maintain heat through wearing warm bundled clothing and layers of clothing. And on the opposite side, we can remove those layers of clothing if we become too hot. If we don't check different temperature extremes, then the eventual result will be death, which I think most people understand. But we have to think of that as being a large part of what we deal with, at the very least here in California, which is overexposure to heat. So some of the things that we need to make sure that we are able to define effectively: the difference between heat cramps, heat exhaustion, and heat stroke. Heat cramps is when the body starts to cramp up due to the lack of the ability to regulate heat, which will cause the patient to have just that, muscle cramps. They will feel like their muscles are, involuntarily contracting and staying there. Heat exhaustion is a bit more extreme, but certainly something that we would expect to see the patient recover from if we give palliative or, supportive measures to help take care of. Heat stroke, without question, without a doubt, is by far the most dangerous and a transportable emergency every single time that we see it, because we don't have the ability in the field to fix heat stroke. We need to take them to a definitive care facility, AKA your hospital. So heat exhaustion. Your body tries to cool itself through sweat. I don't think that anyone's confused on that, but in case you are, that stuff that comes out of your skin and gets you all wet when you're exercising or it's very hot outside, it's called sweat. It's important for maintaining your body heat. Sorry, I'm laughing because I don't think anybody was like, oh, sweat, what's that? But you get the idea. Your body's trying to regulate itself just like it would regulate itself by shivering to warm itself up. As you sweat, your body isn't just losing water, it's also losing electrolytes and the salts and nutrients that are in your body as you start to sweat out, which will, if left unchecked, lead to muscle cramps. Athletes out there know all about this. People that have been in very high heat where they have sweat for a long time without replacement also know this as well. Even the most healthy individuals can experience heat shock as well as heat stroke and heat exhaustion in no particular order if they don't replace not only waters, but also electrolytes, AKA the salts in our body. So where we see this most often is tourists that come visit us here. I'm pointing out to the parking lot, but here in California, as well as other areas that are by definition either deserts, mild deserts, temperate deserts, or Mediterranean type climates like what we have here in Orange County, Southern California. So acclimatization or acclimation to that weather condition is very important, and we see it a lot in the folks that even come to our beaches. Even though our beaches are extremely, humid, moist, whatever you want to call it, they still can suffer from heat-related emergencies, even though they are in a very temperate area. So assessment for a patient that's experiencing heat cramps. We're going to look for a patient that is having muscular cramps. They will likely show signs of weakness or exhaustion, and they will also be perspiring heavily. They will be sweating heavily. These are all early signs. Later signs would be a weak or shallow pulse, weak or shallow breathing, and then, of course, loss of consciousness or even altered mental status. These would be late signs that would say this patient is now degrading into heat exhaustion or possibly heat stroke. in the care of this patient, we want to make sure that we remove them from the hot environment. That's step number one. Get them out of the hot environment. We cannot continue to treat them if they are still in that hot environment. It doesn't make any sense, so don't do it. If the patient shows signs of shock or hypoxia, we'll administer oxygen, and we'll do that through the method that makes the most sense for them, whether that be a nasal cannula, non-rebreather, or if they've progressed truly to the point where they can no longer take care of themselves through positive pressure ventilation, aka through BVM. We'll loosen or remove any clothing that would cause them to continue to heat up, and place them in a supine position. This is so that the body is not in a position where it has to do extra effort, like sitting semi-fowlers or fowlers, which is seated upright. If the patient is alert oriented and has a gag reflex, we can give them small sips of water. But just like in active rewarming, we don't want to have them chugging water, even though that's what their body might be telling them to do, which is drink all the water. That's not going to help them. That'll actually more than likely cause them to throw up. And if you're a student that is in my class, you're probably screaming right now, that causes aspiration. Yeah. Relax. We get it. Yes. Liquids in the airway, bad. Aspiration risk, bad. So that's our consideration why we would only give them small sips of water. They need to acclimatize not only to the lack of water that they have, but also to the environment. We can apply moist towels, which we can cover with our sterile water, or if we have a clean water source available at the site, whether that be, from someone's sink or something like that. Because again, we don't have plumbing in the back of our ambulance. We are not a wet bar on wheels, so we don't have those things. If we can wet something down and then put it over their forehead, back of the neck, in the groin and armpit areas, that will help cool them down. And then we'll transport the patient. Patients that present with hot, dry skin, even if it's slightly moist, but mostly dry and red for certain, this is most likely a patient that is in the beginning stages or fully in heat stroke. This patient is having a true emergency, and by that I mean they need to be transported to the hospital because we cannot fix their problem in the field. Their body is no longer maintaining or regulating body temperature. It's failed to the point where the body is just getting hotter and hotter and hotter, and nothing will step in to fix that. Because the body's unable to get rid of excessive heat, we need to go through more aggressive measures, whether that be active cooling measures like dunking them in an ice bath, giving them medications to drop their blood, not their blood, but drop their body temperature. That's going to be something that's done in a hospital and not in a pre-hospital environment. So we need to make sure that we are supporting them by transporting them rapidly. That's the most important treatment that we can provide under most circumstances. What are the signs and symptoms of heat stroke? Loss of consciousness or severely altered mental status. Rapid or shallow breathing, body's trying to cool itself off through respiration, like we talked about before. Weak rapid pulse, body's not keeping up. The compensatory mechanisms, the heart isn't able to keep up and is beating faster, puts it at very high risk for a cardiac-related emergency to occur as well, possibly through throwing a dysrhythmia or stopping entirely. Generalized weakness is going to be the body just saying, look, I can't help anymore. I can't do what I need to normally do because my systems are shutting down. It's just like your phone, just like your iPhone. When it gets too hot, you cannot continue to use it. It'll say, hey, the temperature of this phone has to go down before I can continue using it. Some of you already know what I'm talking about. For the rest of you, just know that extreme heat, extreme cold doesn't let your phone work. Little to no perspiration. The body is not doing its job. Sweating is what allows us to cool ourselves. And if our body cannot produce sweat, it cannot cool itself down. A plus B equals C. Boom, done. Dilated pupils. This is going to be a neurologic response. The body is no longer able to control the relative size of your pupils, which is allowing light into the eyes. This is a sign that the body is beginning to truly and actually shut down. The dilated pupils may or may not be present, but you can look at the normal neurological response and say, hey, this is or isn't working. Look at that loss of consciousness. Look at that altered mental status and say, when I get hot, do I become so out of it that I lose consciousness randomly in the gym? Or do I become altered to the point where, when someone says, what's your name? And I say potato, everyone's like, that's not your name. If the answer is no, then you should know that as a healthy person, it's not normal. And we want to treat our patients as if they are normally healthy. It's a problem. So we have to treat it. And knowing those signs and symptoms and understanding why they're present will help us understand how our patient presents better overall. We might also see, because of the neurological effects, seizures. These heat-related seizures aren't, they're not a disease in and of itself. Just like I've said in other videos, seizures are an underlying symptom of a larger problem. And in this case, it's the inability to regulate body heat. We may or may not see muscle cramps along with these seizures. So it's something to kind of note that the body is no longer able to control itself. How do we take care of this patient? Well, first and foremost, remove them from the hot environment. It's just like heat exhaustion or heat muscle cramps related to heat. Remove their clothing, and this one's not negotiable. We will have to take off their clothing, keep them down to their skivvies, their underwear. That's probably going to be just enough. And then apply cool packs to the groin, armpits, and the back of the neck. If we're dealing with young children, and remember that young children have a reduced capacity to regulate both heat and cold, so they will likely fall into this category a lot sooner than adults. We need to start by actively cooling them with lukewarm water. Applying too much cold to them, just like applying too much heat, can cause adverse effects. In this case, if we cool them too rapidly, as if we threw them into a cold pool of water, that can actually trigger seizures, and it can trigger other involuntary responses of the body that can be dangerous in and of themselves. So we need to slowly introduce cooling techniques to the infants and young children that we deal with that are experiencing this emergency. These patients need oxygen. A lot of what we're dealing with here, the fact that we call it heat stroke, is that we are reducing blood flow to the rest of the body based on the body's inability to effectively manage itself. So we'll see a lot of those stroke-like symptoms. And finally, we need to transport right away. Cannot delay transport of this patient. So as your body temperature decreases, muscles shiver, your heart is very prone to dysrhythmias, and your central nervous system becomes sluggish. That's why when you're getting very cold, you might be having a harder time forming a thought or using a part of your body. Not that you're thinking, right hand, activate, left hand, activate, but your body will have a lowered latency, an elevated latency when it comes to cause and effect. As body temperature increases, we're going to start to see changes in the skin's relative temperature and its appearance. We'll see sweating lead to evaporation and cooling of the skin to the touch, but internally the body is heating up. And if heat builds up to an excessive temperature, the skin itself will become hot. So feel the skin, but also don't delay using the tools that we have. If we're dealing with a patient and we have it available, we would like to take an internal temperature. Oral temperature gauges are absolutely a relatively worthwhile tool. It's going to be much better than doing a temporal scan where we scan from the temple across the forehead, or a skin-based temperature scan, which I'm sure everyone's used to now that we've gone through COVID-19. But the absolute, defining factor of getting a patient's temperature is central or core temperature. And unfortunately, that's the icky part. We're going to have to take a rectal temperature. Now, if your service has that and you're thinking that this is a heat related or cold related emergency, is it inappropriate for us to do a rectal temperature? Again, if you have it, you should use it. But most ambulance services, most EMS agencies, most fire agencies, in my experience, do not carry these devices. And the reason is because it's unnecessarily invasive. Cold people look cold, hot people look hot, take them to the hospital. That's where they need to go anyway. But like I said, use what your service has, and be sure that if you are going to use these things, that you have the effective training and proper equipment to make it happen. All right, now as you can see, things have changed a little bit behind me. I had to take a pause in recording to get some stuff done around here in the classroom between classes. So sorry about the change. I'm sure that you're all freaking out right now, like, what's happening? But it's just a different time of the day and the sun's directly in my face, so I closed the blinds. Anyway, we're moving on. So we are moving away from temperature extremes, and now we're going to be talking about water-related emergencies. There are several, so this is going to take a little bit longer than, in terms of like one subject versus multiple, but we'll move through it and then we'll move on from there. And I do want to make a quick disclaimer that the water emergencies that we're talking about here, the water-related emergencies that we're talking about here, this is a very, 50,000 feet top-down kind of look. This is not every type of water-related emergency. If you are a lifeguard, if you are any type of water rescue professional, you'll probably be, like my students were earlier, screaming at the screen, like, that's not enough. This is enough to satisfy the necessary knowledge to pass a national registry, at least according to our, our publisher. And I agree, just based on, the information that I've been given regarding the National Registry and the curriculum regarding water-related emergencies. So if you came here hoping for like, oh man, we're going to talk so much about water-related stuff, we're not. And you're probably going to say the same thing about bites and stings later and snake bites. So we'll go from there. All right. So when we talk about water-related accidents, we're talking about things that occur in waterways. And this can go from, jumping into the shallow end of a pool all the way to the kind of incidents that we see with boating and jet skiing and scuba diving. So we're really running the gamut from the pool all the way to the ocean and everything in between, whether it be a lake, a pond, a river, an estuary, a tributary, whatever the areas are, a swamp, anything that you can conceivably say, hey, people will go in the water there, we'll be talking about, with the exception of whitewater rafting type things and, the turbine effects that can be found in some of those rapids and things like that. This is not a swift water rescue course. So if that's what you were hoping for, you're not going to get it. All right, let's move on. So when we are looking at patients in water-related accidents, the brain would probably lead you to think, oh, we're going to be looking at patients that have swallowed water. And to a degree, there is plenty of that going on, but really what we're going to be looking at are all the different types of emergencies that can occur when your patient has been either submerged or exposed to water in a way that they were not really in control of their body. So some emergencies that we can see: airway obstruction. I think that's pretty clear. Cardiac arrest, which again comes from the lack of breathing, which leads to hypoxia, which, leads to death, and going on from there. We can probably pretty logically understand that heart attack would be something that could potentially happen as well. Moving away from the medical side of things and moving into more trauma, we can have injuries to the head, neck, and back, internal injuries, obviously external injuries. We can definitely see some injuries related to hypothermia. And of course, these can all be made more complicated through substance abuse, alcohol abuse, and the granddaddy of them all, drowning, which is the big one that we want to focus on. And for most of you that are working in public safety, you already know that we spend a lot of time talking about the safety of being in and around the water as it relates to drowning prevention, because one of the biggest things that most people don't realize is that when it comes to drowning prevention, understanding how people drown is one of the key factors against preventing it. That and a general understanding of how to protect little ones that don't necessarily understand the dangers of being around water, how to protect them from even getting near it. But that's another video for another day. So we'll start with drowning. According to the World Health Organization, I'm just going to read directly off the slide here. According to the World Health Organization, drowning is the process of experiencing respiratory impairment from submersion or immersion in liquid. Plain simple English here. What the World Health Organization is saying is that when you are in liquid to some degree, going over the, something that's enough to go over the mouth and nose opening, we have respiratory impairment. Duh. The outcomes are death, morbidity, and no morbidity. Death is death. Morbidity more focuses on the damage that's associated with it. And typically when we look at morbidity, we're looking at long-standing damage as opposed to, I got scared. It's usually more, along the lines of a lifelong injury or a lifelong illness that goes along with it. And then no morbidity is, boy, that sure was scary, but there's no physical ailment. There's no, real evidence that this ever even happened. And if you've ever been in a situation where you nearly drowned, I guarantee you remember it. It's one of the things that our brain is trained to say, this is dangerous, don't do it again. And unfortunately, through trauma, it's an excellent way for us to remember not to do it again. So we'll move on from there. Drowning begins with someone that's struggling to stay afloat, or they're really struggling to maintain their level above the waterline while they are submerged in water. When they begin to submerge, they start to take deeper breaths. And, typically when they know that they're going to go down, they're taking a deep breath and then they release and then they try to come back up, and they're going to continue doing that until the body simply can't continue doing it. The swimmer at this point becomes, overwhelmed with exhaustion. They begin to swallow water, small amounts followed by large amounts, and they begin coughing and swallowing. And it's a cycle that becomes more involuntary than anything. And I guarantee that most people have had at least one situation where water is rushed up the nose. They've jumped into the water with their mouth open or something to that degree. They got some water and then went. It's a very violent, sensation getting water into our airway. And when I say violent and you're going, that's violent. Think about the last time you got some water down the wrong tube, the wrong pipe, and tell me about the coughing that you had, especially post COVID-19. You can't be out in public doing that. People will send you home. They'll isolate you. So when it comes down to, getting any kind of fluid into the trachea, it's a very visceral effect. You'll cough really hard. Whereas opposed to swallowing water, which is a normal process for us, that may not feel like it's something bad until we swallow water that we weren't trying to swallow. And that would be, chlorinated, non-chlorinated, or, especially, I should say, ocean water, because we don't like swallowing salty things. It makes us feel bad. So moving forward, and remember, we're still drowning at this point. So, now water is entering the airway, coughing and swallowing, it's involuntary. And now we get into what happens in many people where they have a spasm of the larynx. And remember, the larynx is back here. It's all the way back here. And what happens is when it closes, it seals the airway. Now, that doesn't mean that is what happens in every drowning, but it happens in many drownings. And that leads to unconsciousness from a simple process of hypoxia. If you close the door, no one else can get into the party. And this party is one of those, it's ain't no party like an airway party, because an airway party is mandatory. Yeah, you have to show up. And if you don't have that air moving in, there will be a problem. The party's going to get shut down real quick. So some might find it surprising, but we definitely find drowning victims. And when I say we, I mean the royal we, first responders. We find these drowning victims, and when they perform an autopsy outside of our purview with the coroners and whatnot, they may open the lungs and find very, very little to no fluid inside the lungs because the larynx closed, no air got in, and they simply sank below the waves. Now, that's certainly not to say that some patients don't aspirate a lot of water. They certainly can, and they do, but it's just a little bit better understanding of what's actually happening. Now, one thing that I do want to make a quick note of, and this is going to be to the absolute relief of all my lifeguard watchers. Yes, drowning is one of those things that starts real noisy and looks real, but it ends silently. They say that, the last thing that a drowning person will do is silently boop, dip below the waves. And as scary as that sounds, it's even scarier when you think that someone that looks like they're not having trouble simply disappears from view. So if you are in the water safety realm of things, you've already received a lot of instruction on drowning. It's worthwhile to at least remind you that drownings and when we're looking at drowning victims, they will not give us one last help. They're going to drown without much sound. So drown without sound. Keep that in mind. So how do we take care of these patients, whether it be a drowning or a near drowning event where they aspirated a little bit of water, they maybe had that laryngeal spasm, whether the flying here, whatever the case may be. How do we take care of them? Well, first and foremost, we got to get them out of the water. So get them out of the water. And as soon as they are out of the water, we want to begin rescue breathing. If the patient is in water, we're going to try to keep them semi-supine and then provide ventilation. I just want to throw in a little bit of professional expertise here. In my in my very, very nearly 15 years and 4 months of experience, I can tell you beyond a shadow of a doubt that I've only been in standing water, up to my knees in one call. And I'm sure that there are plenty of people out there like, well, bro, you just don't know. And like, I've actually had to jump in and pulse. All right, we get it, Rescue Ricky. We get it. You're a hero. That's fine. But in my 15 years, I've only had to stand in the water once. What I'm trying to say is if your patient is in water and when you arrive, they're still in water, something drastically incorrect has happened. More often than not, when someone's seen at the bottom of the pool, even the most untrained individual will make an attempt to save their life. We've even, traditionally seen people that can't swim that will jump into the pool to try to help. It's almost human nature. So if I find someone at the bottom of the pool and there's a lot of people standing around going, yeah, gosh, I'm an accountant. I can't help. I have questions, but that's aside the point. Get the patient out of the water and then begin working on them from there. The only people that this really applies to where we're going to provide care in the water would more be along the lines of lifeguards. And, this is going to come into play a little bit later because we're going to talk about the order of operations, what comes first, whether it be airway, breathing, circulation, or C-spine. So don't Don't fret, we will bring it up. When we're ventilating these people, it's very important to mention that you may find some airway resistance. And a lot of that has to do with the laryngeal spasm that we talked about, where everything's kind of closed. So you may need to ventilate a little bit more forcefully than patients. But before you go into this drowning call and you want to go ahead and ventilate Nana, who fell into the pool, and just really kind of get it, wait, just pause. And I'm going to pause right now. I'm telling you right now, this video is just going to be like, start, stop, start, stop. I got a new chair, new office chair. Woo, it's fun. I like it. Okay, so like I was saying before, don't just ventilate as hard as you can. Give it a breath. Give your patient a breath before you start really cranking down, because you don't want to cause airway trauma or force air into the abdomen through the esophagus. So that's just a quick little pro tip for you. As we move away from rescue breathing on this slide, we need to look into the possibility of spinal injuries. Patients that are unconscious, just in general, we want to consider the possibility of head, neck, or back trauma before anything else, because as we've mentioned in other videos, as I've talked about in class over and over and over again, we want to make sure that when we're treating the patient, that we're giving them the benefit of the doubt that something terrible could have happened. And we want to treat as conservatively as possible, meaning that we don't want to assume, I bet nothing happened, because that's not really good patient care. However, when it comes to the potential of head injuries with regards to these drowning patients, while C-spine is important, we need to begin resuscitative measures if they aren't breathing or if they don't have a pulse, because even though their spinal cord is a very important part of their day-to-day, they cannot live if we don't breathe for them, if we don't continue pumping the heart. And I guarantee that there's at least one person on the other end of this video going, well, what if you paralyze them for life? What are you going to do then? Well, you know what? There's a reason that anyone can sue anyone for anything. And there's also a reason that we have malpractice insurance. But I would say that for the most part, if I paralyze somebody and they live, I'm probably going to come out on the other end of that lawsuit looking okay, because instead of them filing a wrongful death suit, they're basically filing a lawsuit saying you saved their life, but they're paralyzed. And there's plenty of case law that shows that most people prefer to be alive and paralyzed versus dead and not paralyzed, because death is always worse. So just something to remember. ABCs comes before C-spine in these cases all the time. And if there's an interruption to the ABC, airway, breathing, circulation, that has to be addressed in general with any patient before we do C-spine. C-spine comes after. If you are doing spinal assessments in the water, you're doing it wrong there. You can't do it in the water. They've got to be outside of the water. So bring that backboard in, strap them in, get them out of the pool. And like I said before, for the most part, I personally have never gone to a drowning call where the victim was still in the water, not once. Am I saying it never happens? No. Am I saying that it won't happen to you? Absolutely not. But in a controlled setting like a pool, a lake, a pond, things like that, we don't typically find patients in the water. And even in our water rescues out, out on the beaches, our lifeguard staff, our marine safety personnel, they usually, by the time we arrive on scene, they've got the patient well out of the water. So only under the most, unique circumstances would I ever anticipate the patient being in the water. So it's just a quick note. We can't do a full spinal assessment in the water for the simple fact that we're in the water. So we got to get them out. If we suspect spinal injuries, and like I said, unconscious patient, don't really know what happened, we definitely want to take spinal precautions, but we don't want to delay basic life support, because again, at the end of the day, if they die, it doesn't matter if they were paralyzed by our care, they still died. So just keep that in mind. Keep the patient's neck supported, keep the spine in line, keep it straight, but BLS. Also, make sure that you are getting effective information from personnel that are on scene, especially on these unconscious drowning patients. We want to know when the last time they were seen, the last time we saw them swimming. Let's just call it that way. I would rather not say the last seen alive, because that sounds a little dark. So we want to go with the last time that we saw the patient actually moving on their own, the last time we saw them above the water line, and we'll move forward with care from there. Diving accidents. Now, this is very specifically talking about diving accidents, not, diving accidents. So just so everyone's clear, diving means diving into a pool, diving into the surf, pond, lake, river, estuary, whatever. I don't think you would dive into a swamp, but that's just me. The injuries that we're going to be looking at are going to involve the head and neck, but may also involve hands, feet, and possibly the ribs. And then, of course, when we're looking at diving, anything that contacted the water first. But for the most part, head, neck, back, that's what we're going to be focusing on. And then anything that may have encountered the hard surface, not the water, the hard surface before the head, neck, back. So take that into consideration. It's the same of any patient that we would see, I suppose, diving into concrete, because at the end of the day, if you dive into the shallow end of the pool, are you doing anything different? The answer is no. We're slowing ourselves down by but a fraction of an amount. It's not really that different than diving directly into concrete. And anyone that says otherwise is not thinking of this as someone that dove in with anything besides the intention of, I know I'm diving into a very shallow pool. Because for the most part, when we talk about these kinds of diving injuries, it's someone that dives into an unfamiliar pool of water or an unfamiliar body of water. And then, typically is expecting it to be much, much deeper than it actually is. And then, they go ahead, and that didn't make any sense. They cranked their head over that way. This doesn't make sense. All right, so that is what we refer to as a diving accident. Scuba diving accidents, very different. Very, very, very different. So let's go ahead and talk about what these scuba diving accidents look like. We need to be on the lookout for any type of scuba diving that occurs in our first due, especially if we're working in areas where diving is considered to be recreational as opposed to industrial. Why recreational versus industrial? Well, recreational diving can be done by anybody that's received training in a pool typically. And we see a lot of folks that get into this without really the proper, maybe not no training. I don't think I've ever seen a scuba diving accident with someone that's never trained before, but they might not have been under the appropriate supervision for diving at the level that they were. Whereas with industrial divers, that's usually not nearly as deep as you would expect to see with these kinds of accidents. So we'll start with the first one, arterial gas emboli or embolism, where we have gas bubbles that build up in the bloodstream. This can occur from the diver holding their breath. It could be due to poor training, equipment failure, an emergency underwater, or an attempt to conserve air. But really at this point, we have a gas building in our bloodstream that is not supposed to be there, which I'm sure all of you watching the video are like, gas in the arteries. Sounds bad. You're correct, viewer. You are correct. It is bad. So what can occur from all this? Well, we've got decompression sickness, the possibility of air embolism, and we'll move on from there. So decompression sickness. Diver surfaces from a dive fairly quickly, too quickly. They don't do their appropriate safety stops. And any experienced or, relatively new diver will tell you that safety stops are absolutely a part of every single dive. It doesn't matter if you're having fun or if you're doing it professionally. Every single scuba diver will tell you these are the things that you need to do. It really comes down to compression and pressure. But at the end of the day, humans do not go below sea level without doing it as safely as possible, without having those nasty side effects. So it's important to remember here. This can take anywhere from an hour to 2 full days, 48 hours to appear. So even if you are running a call with a patient that is nowhere near a body of water, they're not near a recreational dive spot, that doesn't mean they can't have these kinds of things. So be on the lookout for the signs and symptoms of both air embolism and decompression sickness. The signs and symptoms would be, and these can range from early to late. It really depends on the overall presentation of your patient. Altered mental status, rapid loss of consciousness, blurred vision, seizures. And think about this for a moment. Where is all this located? It's all up in the brain. These are all neurological signs and symptoms. So we're dealing with something that's affecting the brain. Other aspects of this, and again, these are a mix of early and late: paralysis in the extremities, stroke or stroke-like symptoms, and that's down at the bottom there. Numbness, tingling sensations in the extremities, especially fingers, toes, hands, and feet. Generalized or specific weaknesses, whether that be, on one side, both sides, one area, or many. We can also see frothy blood in the mouth or nose, and that frothy blood or sometimes frothy sputum is an indication that we are definitely dealing with a mixed gas and something that's coming up into the lungs. Incontinence, ×1, ×2, doesn't matter if you're going in your shorts there. It's a bad day. And then finally, chest pain. And a lot of that has to do, again, with the lack of oxygen going to the myocardium, to the heart. Just like chest pain from anything in the ACS family, whether it be angina or a myocardial infarction. These are the kinds of things we expect to see when we have organs that are not receiving proper perfusion. In air emboli or air embolism, we can even see things as, as significant and serious as a myocardial infarction, aka a heart attack, or respiratory and or cardiac arrest. This is the same as an embolus that would cause a stroke, whether that be due to plaque, improperly clotting blood traveling through the body, a foreign body that is possibly traveling through your bloodstream, or in this case, air. Any type of emboli, any type of stoppage or blockage of the arteries of the blood vessels. That's going to cause problems further down the line. So you have to pay attention to those things, because without that blood going to the right organs, the organ will die. Now, decompression sickness is something that I think a lot more people are familiar with. This is familiar to folks that have either read or heard about it in the movies. It's popularly referred to as the bends. This is where you get pain in the muscles, the joints. A lot of people call it the bends because it can cause patients to involuntarily, just out of pain. At least that's the way that it's been described to me. And we can have a lot of the symptoms that we see from an air embolism: altered mental status, all the related symptoms that came along with that, fatigue, and itchy or mottled skin. Itchy being, just like what it sounds like, it's itchy. Mottling of the skin is typically where you've got, well, actually, you can kind of see it on my hand. You see where some areas are kind of red, some are kind of palish white. That would be mottling of the skin. And I'm doing that on purpose by pushing my hand out as far as I can and really straining the capillary beds. But when we see this in someone that's not trying to do it, especially if it's on, the chest, the extremities, these are problematic signs and symptoms, and we have to pay attention to them. If we don't, the patient might start to decompensate. And a lot of what we're seeing there is blood that is not effectively getting to the capillary beds, which we all know is a problem. It's a big problem. Now, decompression sickness can have other signs and symptoms like numbness or paralysis. Perfect timing. Coughing, choking, dyspnea, aka shortness of breath, or substernal pleuritic chest pain, which is a big fancy word for my chest hurts. We can also see coughing and in some of the later stages, peripheral edema and swelling. And for those of you that are not familiar, peripheral edema speaks to the hands and feet, fingers and toes becoming swollen. Water is being shunted from the blood vessels into the tissue, into the interstitial spaces, and it's being stored wherever they've got a little bit more space. So when you start to see kind of clubbed looking fingers, clubbed looking toes, feet and hands that look a little bit swollen, not comically swollen, but a little bit more swollen than normal. Maybe you can even press in and see a little indentation that takes a little bit of time to come up. These are the signs and symptoms that we anticipate to see in a scuba diving incident or a scuba diving accident. Now, what are the emergency care steps? It's the same as what we've already talked about with our other patients. Open the airway, maintain the airway. Give this patient oxygen, because at the end of the day, the majority of what's in their bloodstream is nitrogen, which we breathe every day. It's not a big deal. But if we don't have enough of that nitrogen if we don't have enough, or if we got too much of that nitrogen in our bloodstream, that's going to make a problem further down the line. We need oxygen. So this patient, amongst any of our scuba diving accident patients, they need to have oxygen. And the signs and symptoms should point towards give them that drug. We also want to keep this patient warm. Why? Don't worry. I'm going to tell you right now. If your patient has had an extreme event like this, the likelihood is that they will not be able to maintain body temperature based on the fact that their body is fighting to stay alive already. So we want to make sure that we are assisting that process by warming the back of our ambulance, utilizing blankets, both passive and active warming techniques being utilized appropriately. And if your scope of practice allows for something that's a little bit more in depth, that's, such as humidified, warmed oxygen, or if you are allowed to give them, small sips of warm water, feel free. But again, airway, breathing, circulation, by far the most important things. And don't forget, we may need to use C-spine immobilization to immobilize them. And you might be wondering, especially if you're not from here in Orange County, if you're saying, Well, why wouldn't you do full spinal immobilization? We do something a little bit differently here. It's called spinal motion restriction, or SMR. And in a SMR, we prioritize management and immobilization of the neck, the cervical spine, and then the rest of the back. We really don't go down the line of using a backboard anymore because we found that it actually causes more damage than it prevents in many of our patients. We still use backboards, it's just not as emphasized. And I think that many departments and many areas throughout the US have moved over to this type of thinking. I think that we hit all the bullet points here. Contact medical direction for specific transport instructions. That really just goes down to where we're going to take this patient. Scuba diving accidents traditionally have been, able to be seen in the emergency room, but where they will receive what we call definitive care is in a hypobaric chamber. And in these, hyperbaric chamber. Hypobaric. What's wrong with me? Hyperbaric chambers are not found at many hospitals. I can tell you that here, our local hyperbaric chamber is actually off the coast of California on Catalina Island. So, that's going to involve, at the very least, flying our patient to that location. So we want to make sure that they're going to the right hospital so that they can be transferred effectively and appropriately once their initial treatment has been completed and once they've been stabilized to the point that we can get them there. And for all of you, folks that like to fly out there that are saying, we might not be able to fly them based on the fact that they need to go to a hyperbaric chamber. Hey, you know what? You may be correct. It is a bit out of my wheelhouse transporting those patients there because my ambulance doesn't go in the water. But if you have answers on that, on how we transport those patients to Catalina Island, please put it in the comments down below. I'd love to know. And then don't delay transporting this patient. They need to go to the hospital. That's really where they're going to get the best care. And that's where we're going to be able to take care of them on a long-term basis. Water rescues. I'm going to keep this very short, sweet, and to the point because, again, this is not focused on water rescuing. There are very, very, very fantastic courses on this, and there are entire Swiftwater courses that you can take as a rescuer. It would be completely outside of my area of expertise to speak to this. So I want to make sure that everyone is abundantly clear that that's not what we're going to be focusing on. But water rescue, reach, throw and tow, row and go is the going knowledge. By reach, we want to give the patient something that they can grab. So I'm sure that all of you have seen the rescue rings that they have. It's the circular thing. It's got some rope, little attachments on the side, and it's got a tow rope attached to it. You can throw that out to them and then pull them back to shore. The same can be said for throw and tow. And then we've got row, where we can actually move a boat out to the patient. And the reason that we say row the boat out to the patient is because, hey, if you're under your own power, if you are under human guided power, we know that that engine's not going to die. And then finally, we can swim to the patient, which would be your absolute last resort. We should only swim to the patient if we have a personal flotation device for ourselves. We are effectively trained in water rescue. We are strong enough to beat not just the weight of water, but also the weight of the current conditions and the weight of the patient, who will likely be fighting our rescue just because they are fighting to stay afloat. And here's a little picture for you of all these different bits and pieces. But in that order, it goes reach, throw and tow, row, and then go, which is to swim. Swim. All right. Ice rescues. The number one rule is to protect yourself. I can tell you right now, ice would be completely outside of my element because in Southern California, we don't really have ice rescues unless you go up to the mountains. And even there, our lakes don't really freeze over. So what I would say here is be safe. Use flotation devices, whatever the case may be. Try to get out to them in an aluminum boat or flat bottom boat, or lay some type of device to get out to them on the ice. What they are saying here is the very last thing you should ever do is go out onto the ice, because you may become a victim in and of yourself. And I will say this, if the patient were to float below the ice, that's obviously a negative thing, but cold water drownings are the most efficient way for the patient to, for lack of a better word, self-preserve, because we have a much higher chance of resuscitating them if they slip under the water and they are down there, for any extended period of time. Studies have shown that people have survived for, up to multiple hours after being submerged in ice and then resuscitated effectively with little to no side effects or morbidity. So no morbidity. After we get the patient out, we want to immediately treat for hypothermia. Any kind of clothing that they have on needs to be off. We need to cover them in a dry material, and then we need to transport this patient. And it says always transport. If you fell into the ice, that is not a go home and shake it off kind of event. You need to be seen in a hospital. And again, like all of our calls, safety comes first. So don't work this one alone, and never walk out onto the ice. Never, ever, ever. And for those of you that live in these areas where you get, lakes, ponds, bodies of water that freeze over, you're probably saying, well, duh. Remember, we surf in Christmas time. So we don't know. All right. High altitude emergencies. Hey guys, we're almost done. We're doing a really good job. Let's continue this, and then we'll be done and do our review, and then you'll be on your way. We have 3 different types of high altitude illness that we're going to be talking about today. And again, if you're going to be doing an outdoor course, please refer to that outdoor course. That'll give you more information on prevention, care at altitude, and then removal, like making a makeshift litter and things like that, and self-extrication. Remember, not every single one of you will be able to get help. The going term is expect to self-rescue, expect to self-extricate. Be the kind of rescuer that doesn't need rescuing. We have differences when we go to different altitudes. There's less air to breathe. There's decreased air pressure. Therefore, it's going to be more difficult for us to breathe. Now, if you are healthy, once you've acclimatized or adjusted to these areas, you don't need to work as hard to breathe. For those of you that live in places like Denver, for those of you that live above that, 6, 7, 8,000 foot mile marker, or 6,000, 8,000 foot, not mile. Good Lord. Be on the moon. No, not quite. But you'd be up really high, way too high. You would die. So high you would die. But when you live above, 7, 8, 9,000 feet, you acclimatize over time. People that are visiting these areas will not normally experience these, types of negative experiences because they are not under strain. So we're looking at people that are hiking in the mountains, or people that are mountain biking in the mountains, things like that. The first one that we're going to talk about is known as acute mountain sickness, or AMS. AMS is really less severe than any of the other emergencies that we're about to talk about. They're adjusting to thinner air. And in, the majority of cases, all that they're really going to need to prevent AMS from progressing is to rest and rehydrate at that same altitude. So not descending, they're going to stay exactly where they are, but they're going to rest, rehydrate, and then continue on when their symptoms go away. However, in more severe cases, we might actually need to give this patient supplemental oxygen and then descend to a lower elevation. And for any of you that have ever done climbing up in the mountains, especially here in Southern California, where the majority of our residents live at or just above sea level, you can feel this when you go on a hike up in Big Bear, Lake Arrowhead, any of those areas at elevation. You can feel that when you go snowboarding or skiing. And if you don't have the equipment to fix this, if you don't have supplemental oxygen and you're starting to feel really sick, the best thing you can do is descend as soon as it's safe. Now, moving away from AMS, or acute mountain sickness, is HACE. HACE stands for high altitude cerebral edema. High altitude cerebral edema is the worst version of acute mountain sickness. So this is the progression of AMS. AMS can progress to HACE. HACE is shown with the following signs and symptoms: headache that gets worse over time, so a progressive headache, loss of balance and coordination, severe fatigue, possible seizures, mental status that is certainly not with it. They're altered, and possibly loss of consciousness. Now, these are all pretty significant, with the exception of the headache. These are pretty significant findings. And if you are in one of these places where you're at an elevation and someone in your group or yourself are feeling these signs and symptoms, the best thing that you can do is, get back down the mountain. So, inpatient care, it says here, arrange for immediate descent. All the other treatments are going to be secondary. If they can be initiated while you're heading down the mountain, hey, good for you. But we're not going to stop, apply oxygen, and then go back down the mountain. We're going to start going down the mountain, and as soon as it's safe, as soon as we are able, we'll apply supplemental oxygen and then provide any supportive treatment. In this case, supportive treatment would be being on the lookout for nausea, vomiting, being on the lookout for any loss of consciousness, and specifically looking for any other signs of injury or illness or, possible other, sources of the reason the patient is feeling this way. Now, so far we've talked about AMS, acute mountain sickness. This is high altitude cerebral edema, or HACE. There's one more illness that we need to talk about, and it's called HAPE. HAPE is high altitude cerebral, oh my goodness, high altitude pulmonary embolism. High altitude pulmonary embolism. And I'm going back in the slides here. High altitude pulmonary embolism is anytime that we've got a patient that's showing the signs and symptoms of PE, or pulmonary embolism. We'll see a lot of the same symptoms, shortness of breath, coughing that may include or begins to include blood, tachypnea and tachycardia. Tachypnea being very rapid breathing, tachycardia is elevated heart rate. We might see that the patient's core temperature is going up to 100.4 to even higher. And we're definitely going to see a lower oxygen saturation. It says here on the bullet point, oxygen saturation lower than that of other asymptomatic people in the same environment. If you're a provider that works in one of these mountain cities, mountain towns, and you have a patient showing these signs and symptoms, would you check off of your SpO2, or would you check off the SpO2 of another person in their group? The obvious answer would be another person in their group, especially if they are not acclimatized to that specific altitude, because we want to check them to the average individual. And if they're lower than them, that would certainly be a problem, because it shows that their airway is not effectively allowing for respiration to occur, that exchange of gases in the alveoli, where we've got oxygen going in, carbon dioxide coming back out. Finally, and this would obviously be a very late sign of HAPE, we have respiratory failure and respiratory arrest. High altitude cerebral edema is more serious than HAPE. So HACE is more serious than HAPE because, again, these patients that are experiencing high altitude cerebral edema, they have pressure that's building in the brain, whereas pulmonary embolism can likely be cleared by immediate descent. So remember, in both cases, HAPE and HACE, we want to immediately descend. And if the patient is even showing some of these symptoms in AMS, remember that it can progress to HACE, high altitude cerebral edema. So we want to look for these severe signs and then descend. However, if the patient has already stopped and they feel better and they've gotten some ability to rehydrate and they feel better, they can continue on, but we don't want to mess with these things. That headache isn't going to get better. That shortness of breath is not going to resolve itself. So descend if there's any question that they're not getting better. Whew. All right. We're going to be talking next about bites and stings. This might be the longest recording I've ever done. I don't know how long the video is going to be, but the timer says I've been recording this video for 4 hours and 10 minutes. All right, let's finish this up. So we're going to finish up with bites and stings, and then we'll do a review of the chapter as we always do. Couple of quick notes for you. Insect bites and stings is the topic header, so let's be really clear. We're talking about insects and specifically spiders. All spiders are venomous, and before anybody Wikipedia's that one all the way to death, what they're trying to say is that spiders use venom to kill their prey. Not all venom is dangerous to us humans, but all spiders are venomous. So that kind of leads to the next point. Insect stings and bites are rarely dangerous, but anaphylaxis is a major concern, especially if we're dealing with the type of insect that can cause a large group of our population to end up having an anaphylactic reaction. And I think you all know what we're talking about. Yes, that's right. Giant bees from outer space. No, wait. No, just regular bees. Space bees don't matter, just regular bees. That can actually cause a lot of us to have anaphylaxis, me included. So anaphylaxis, which we've already talked about in a previous chapter, is something that we will be, severely affected by as humans. And it's kind of like pouring concrete down the airway. So we definitely want to make sure that we are not losing our patient based on the fact that we cannot open their airway, especially when we truly can. If our agency, like around here in Orange County, we're allowed to carry epinephrine auto injectors, and we can give that to our patient, or if the patient has an epinephrine auto injector on their own, that we can help assist them to deploy. But that is aside the point. What we want to know is that these spiders, insect bites, these insect stings, whatever the case may be, we need to treat them with care. It says here to remove the stinger quickly. That's if a stinger is present and if you have the right tools to do so. So before you go and you pull out your credit card or some other type of device to scrape it out, let's make sure that we got the right device, because I don't think that there's such a thing as a medical grade credit card. Now, this is an example of a spider bite, and some of you are saying, brown recluse. Look, I'm not going to get into it, but I can tell you right now that brown recluse bites, at least here in Orange County, California, are not very common because they are not exclusive to this area, and they certainly are not native to this area. They're native to more humid climates like in the south of the United States, not here in the semi-arid Mediterranean climate that you find yourselves in. However, brown recluses have been found here in California. And how did they get here? Well, probably through shipping. So just a quick little side there. Signs and symptoms, altered mental state, and these are all over the board, from very serious to not serious at all. Altered mental status, stings or bites that can be noticed on the skin, puncture marks, blotchy or mottled skin, like we talked about, some a little bit red, some a little bit clear or white, localized pain or itching, numbness that we can see on the body parts, burning sensation at the site, followed by pain, redness, swelling, blistering, and then these are the really serious ones: weakness or collapse, difficulty breathing or an abnormal pulse rate. And then, of course, the other stuff that we can tend to see with just about anything: headache and dizziness, chills, fever, nausea, vomiting. At this point, we need to be able to say, hey, we found a bite, we found a sting, because a lot of these side effects that we can see can actually lead to a lot of things. So take the symptoms that you have and trace them back to the organ set that they come from. If it's, nausea or vomiting, before you say, oh, that's gastrointestinal, remember that a lot of nausea and vomiting can come from disturbances within our neurological system. So we want to make sure that we aren't thinking, hey, maybe this is neuro. And anything else that would affect the central nervous system, we definitely have to think about neurological deficits or neurological injury. Back to the list here: muscle cramps, chest tightening, definitely a bad thing, joint pain, excessive saliva formation, also known as lacrimation, profuse sweating, and anaphylaxis, which is the very rapid or the very most extreme version of an allergic reaction. Sorry, guys. So we got that whole list of signs and symptoms, and just so everyone's clear, I'm going to go through it again: altered mental status, noticeable bites or stings on the skin, puncture marks, blotchy skin, localized pain or itching of the site, numbness in a limb or body part, a burning sensation at the site, followed by the pain that spreads throughout the limb, redness, swelling, blistering of the skin, weakness or even collapse, possibly syncopal, possibly otherwise, difficulty breathing, abnormal pulse rate, headache, dizziness, chills, fever, nausea and vomiting, muscle cramps, chest tightening, joint pain, excessive saliva formation, profuse sweating, and anaphylaxis are all possible signs or symptoms of being stung or bit by an insect or spider. I feel like I'm running through a list of side effects of a medication. Be sure to talk to your doctor if you have the following signs or symptoms: chills, fever, nausea and vomiting, muscle cramps, chest tightening, joint pain, excessive saliva formation, profuse sweating, anaphylaxis, sleep crime, or development of a unicorn horn. Look, the thing that they're trying to, bring home at this point is that there's a lot of signs or symptoms that can go along with this. But if you look at all of them, you can say they all sound negative, and they sound kind of like the person's been, I don't know, poisoned. It's because you have been. That's the purpose of this venom, of this poison, is to cause a lot of these things. And depending on how much we weigh, how old we are, and how susceptible we are to these poisons, we're going to have a different slew of signs and symptoms. So let's talk about emergency care for these. First and foremost, treat for shock. If the patient's going into shock, treat for shock. Again, shock is what? That's right, boys and girls, hypoperfusion. Absent or not sufficient perfusion. If you have some type of specific protocol, you'll likely need to call medical direction, or you need to follow down that standing order that you already have from your system. So make sure that we aren't breaking the rules. And like I said earlier, if we don't have a medical device, we probably shouldn't improvise too far down the line when it comes to removing something that could potentially, envenomate us or poison us, like a stinger. So if you see a stinger and you go, aha, guess what? I've got my crazy credit card with the crazy APR, like 37% interest. Don't bust that out for a couple reasons. First of all, that interest rate is way too high. And second of all, because it's not medically part of your scope of practice. I don't know any EMS system that says use your Capital One card today to remove stingers. So we want to try to remove the stinger or venom sac if we find it, but above all, be safe. Use scene safety. Next, we want to remove any type of jewelry from the affected limb. And before you say, yeah, and then put it in our pocket. No, we want to take the jewelry off the affected limb because what is a potential side effect of the envenomation? Swelling. If swelling occurs and we don't remove it, that can actually get stuck. So if I was stung on my hand, I would definitely want to remove my ring and this watch because they could potentially become stuck and they could unnecessarily restrict blood flow and potentially need to be removed using an emergency device. And I can tell you right now that if they have to remove my ring or my watch with an emergency device, I'm going to be unhappy. Finally, we want to make sure that we keep the limb immobilized. And this goes across the board for snake bites, insect bites, any type of envenomation, because the less the limb moves, the less the poison will be, engendered to go through the body very quickly. Snake bites. They do require special care, but they are not usually life-threatening. Well, why, Mr. Johnson? Because snake bites, and this is regardless of if they are venomous or not venomous, are rarely going to be a full venom bite. A lot of snakes will bite, especially adult snakes will bite an individual as a defense mechanism. No snake out there looks at a human and says, lunchtime is going to be delicious. I cannot wait to eat an EMS instructor. There's no snake out there that looks at us as prey. They look at us as a predator. And because they are not planning to eat us, they won't use venom. Venom is used to paralyze and in some snake species, partially begin the digestion process of their prey. So when they go and they bite us, it's usually a dry bite. And it's just to say, hey, you can admire me from afar. I'm pretty neat, but I don't want to get bit. If you know what I'm talking about, then, go ahead and laugh. Yeah, taking ourselves a nature walk. So death is not sudden unless anaphylaxis develops. So all those movies that say, yeah, if you get bit by this snake, 30 seconds, you're dead. That's not really the case. We do, however, want to stay calm, make sure that our patient is calm and at rest, and consider immobilization to slow venom spread. Notice how it doesn't say anything about using a tourniquet or stopping blood flow. It's because for the most part, EMS agencies want us to immobilize and transport as opposed to cut off blood flow on this one. And we'll talk about why in a moment. Signs and symptoms of a patient with a snake bite. If your patient says, 911, please help. I think I've been bitten by a snake. All right. Did you see the snake? No. That doesn't quite it doesn't quite pass the smell test in my book, but we're looking for bite marks. We should see pain and swelling in the area of the bite. It may take 30 minutes to several hours to develop, but we should at the very least see puncture wounds. We should also see some signs and symptoms that would, go along with it, pain at the site, some type of evidence of snakes being in the area. If they were in an indoor space, I'm a little less convinced that there was a snake in that spot, but snakes go all over the place. And then of course the other types of signs and symptoms that we're expecting to see if they were envenomated, like rapid pulse, labored breathing, general weakness that's progressive, so it gets worse over time, vision problems, whether it be dim or blurred, nausea, vomiting, seizures, drowsiness, or unconsciousness. And of course, seizures, drowsiness, unconsciousness, those are very, very late signs. This means that the venom is doing its job. It's really messing our patient up. So how do we take care of this patient? First and foremost, scene safety. If the snake is hanging out, just, waiting for more victims, it's a weird snake. But, normally once it's, sufficiently scared off its prey, the predator, it kind of dips, it leaves the area. It doesn't say, all right, yeah, I got you. Call your friends. I'll get them too. It's not like that. Remember, they view us as predators, not as prey. So If your local agency tells you to call for medical direction, call for medical direction. And the National Registry says that during a snake bite, we should call medical direction specifically because they want us to go to the correct hospital. We need to go somewhere where they have what's known as antivenom or antivenin. It's the same thing. Antivenom, you know, what we give after you've been envenomated, or antivenin, which is the same thing. Treat for shock, conserve body heat. Definitely important because, again, your body's being poisoned. It's not going to be able to maintain its own body heat, especially if it was not a dry bite, it was a wet bite with venom. It's going to be worried about fighting off the potential invader that's in the bloodstream, in the body. Keep your patient calm. Definitely locate the fang marks, and do yourself a favor. There's a little pro tip. Circle the area, because if the area is swelling and it gets larger and larger and larger, and we circle it, and that circle all of a sudden looks like a small little dot on top of a large mound, that's an important thing to know. We want to know how big it's getting and over what period of time. Remove jewelry, or any jewelry on the extremity, any type of clothing on that extremity. So if it's a long sleeve, go ahead and cut the long sleeve off. If the patient is wearing a t-shirt, we're probably okay, but get clothing out of the way. Keep their extremity that was bit immobilized, and then transport the patient. And think about this for a second. Where do we expect insect bites or snake bites to be? Well, on the extremities. If you got bit on the face, I'd be a little concerned. If you got bit on the stomach or on the back, I have real questions like, what were you doing rolling around on top of snakes? Most of the time people get bit or stung because they're sticking their hand where it doesn't need to be, or where some, creature is making their home for the moment. So moving forward, and actually to our last slide before the review, we have poisoning from marine life. This is something that a lot of my students, funny enough, come into my classroom, especially after they've gone surfing, and normally they come hobbling in and they're still wearing a wetsuit, and they go, "Mr. Johnson, bro, I got hit." Because that's just the way that my students talk sometimes, because we work in Southern California, and let's be honest, when the beach is 5-10 minutes away from school, you're going to get a lot of surfers that come through, and I love it. And they come in, they have definitely been hit because they stepped on a stingray. Stingrays are a big thing for us here in Southern California, and they have a large barbed tail that can go right through the foot. So I just want to make sure that everybody's good to go on this. On a stingray injury, contrary to popular belief, you do not urinate on it. You don't urinate on anything. So if you were thinking, oh man, I like EMS, but I don't want to have to pee on anyone, don't worry. Nobody, you don't have to pee on anyone to be an EMS. I promise. I promise. Urine doesn't do anything for any of these marine life injuries. And if any of you are on the other side of the screen, screaming, "What about jellyfish?" Yeah, that's fine. You can do more with vinegar. Use a vinegar and water dilution and pour that onto any type of jellyfish stings. But that's not what we do on stingrays. Stingrays, the foot or the affected part would need to be dunked in a tub or in some type of trash can filled with a fairly warm water. So water at least 105 to 115 degrees. Anything higher than that, you're probably going to burn yourself, but it needs to be hot water, not warm, hot. Okay. Make sure that if we are dealing with this, that we are washing off the area with fresh water. Fresh water if we're dealing with, wait for it, an injury that has already been effectively treated with vinegar and water and or with hot water. It says here, fresh water activates toxins on the skin, increasing pain. That is only for jellyfish. It's only for jellyfish. So I just want to make sure that everybody's good to go on that. Jellyfish, freshwater, bad. Jellyfish, saltwater, that's fine. But really, vinegar is going to be what kills it. Stingrays, hot water, submerge the part. Definitely go to the hospital because you probably want to be up to date on your tetanus. Not that, stingrays carry tetanus, but you did have an open wound on the beach. And if you're around here, especially in Southern California, our beaches are not clean. So you want to make sure that you got that, and then possibly some take-home antibiotics if you do start to develop any signs or symptoms of an infection. All right, let's do this chapter review, folks. Here's the chapter review, and as always, I'm just going to read the slides off just so that everyone is real clear. I'm going to minimize my face just a little bit. Patients suffering from exposure to heat or cold must be removed from the harmful environment as quickly and as safely as possible. Agree. Generalized cold injuries involve cooling the entire body, also referred to as hypothermia. Yes, good so far. Treatment decisions are based on whether the patient has normal or altered mental status. Sure, I agree with that too. Patients who have hypothermia with altered mental status are considered to have severe hypothermia. This indicates a life-threatening emergency. Definitely agree on that one. If your patient is so cold that they can't put two thoughts together, if they can't tell you who you are, or I'm sorry, who they are, where they are, what time it is, and what's going on, or as my students will learn, PPTE, person, place, time, and event, that's definitely a life-threatening hypothermic emergency. Local cold injuries, on the other hand, involve isolated parts or part of the body, and that's what we refer to commonly as frostbite, which we can begin the rewarming process of. Remember, if we have rewarming that's occurring, it should be only under our local guidelines that say, hey, this is what you can and can't do. The faster that we warm up a part, the worse we can actually make it. So it's super important that we do not rewarm so fast that we actually cause the expansion of these frozen parts that can cause permanent tissue damage or death. So it's very important. Hyperthermia, the other side of the coin, is a heat-related emergency. Its severity is dependent on skin temperature. Skin that's normal to cool is considered less severe than skin that is hot to the touch. Think normal to cool, heat exhaustion. Normal to cool, heat exhaustion. We should see some sweating going on there as well. It should be profuse or at least moist. If the patient is hot to the touch and they're dry or very barely sweaty, we're thinking more heat stroke. All heat-related patients should be removed from the heat and cooled. Duh and or obviously. Excuse me. Altered mental status, any of these patients in the hyper or hypothermia category that have altered mental status are definitely showing you, hey, I'm having a life-threatening emergency. I should be transported as quickly as possible. This is not a stay and play kind of situation. This is a load and go. If your local protocols allow you to do rewarming or cooling procedures, follow them. As a basic tenet, we want to make sure that all of our procedures are done in a way that does not shock the system. So dunking someone in an ice bath is usually considered to be a big no-no unless we have a specific protocol for it. And I'm speaking specifically to the kinds of protocols that we see in event medicine. And I'm speaking directly to, all my friends out there that work in the rave scene, because we actually do something like this under medical supervision of doctors and under very, very different circumstances. So for us out in the field on the ambulance, I don't know if for some reason you're listening to this on your way to a call, don't shock the system. Don't shock the system. Okay, moving on. Immediate resuscitation of water-related emergency patients may require quick and persistent intervention. Good so far. Ensure your own safety before attempting any sort of rescue. Totally agree. Scene safety comes before everything else. Your safety, then your partner, then your patient. They're number 3. They are in third place. Bronze. You, gold. Partner, silver. Patient, gold. I'm sorry, bronze. Colors, hard. And then finally, bystanders. Last, for injection or ingestion of the venoms of insects, spiders, snakes, and marine life, call medical direction and follow your local protocols. I agree with all that. I think that when it comes down to envenomation, the best care for your patient is to take them to the hospital because they have what you need and what the patient needs to get better. So make sure that you take them there. And of course, don't get stung or hit yourself because you're going to end up becoming a patient. Don't become part of the call. Now, heat is lost and gained through convection, conduction, evaporation, respiration, and radiation. So those 5 ways. Again, that's convection, conduction, evaporation, respiration, and radiation. Some illnesses, medications, underlying conditions, and injuries can make patients more susceptible to heat and cold injuries. These are the types of things that can make our patient more susceptible to ill effects, to negative effects. Next, actively rewarm alert and responsive hypothermia patients. Sounds good. Passively rewarm hypothermic patients with an altered level of consciousness. And I would say this with a big grain of salt because passive and active rewarming are definitely different, but it depends on your local protocols on what you can and can't do. Passive rewarming is something that any local protocol would say, do that. That means remove cold or wet clothing, replace with warm, dry clothing or blankets, something to that degree, and then gradually increase or turn up the heat in the back of the ambulance. Whereas active rewarming is when we're immersing the spot or immersing the area in hot water. We are using heat packs to try to rewarm them, or we're using a device that actively applies heat to rewarm the patient. On the other side, we've got patients with signs of heat exhaustion. The EMT must assume heat stroke is present. Active cooling is essential. I can agree with that to a degree. I can agree to a degree. So the EMT must assume heat stroke is present. Look, I want to treat you guys like the intelligent individuals that you are. I don't think that EMTs assuming that heat stroke is present is the appropriate way to go through things. They're asking you to be conservative, to rule out heat stroke before assuming it's heat exhaustion or just a heat-related illness. So instead of presuming they have heat stroke, because that's going to put people into a bad spot where they can actually provide care that is deficient, let's presume that that is the worst case and then rule that out, making sure that we don't see those signs and symptoms of heat stroke. And we can look at skin signs right off the bat. If they're hot, dry, or nearly dry, that does sound like heat stroke. We have to combine that with altered mental status. If they are hot and dry in a hot environment and they have altered mental status, that is heat stroke. But if we don't see those things put together, oh, by the way, I mean hot and dry or very, very little skin moisture. But that paired with altered mental status, that is heat stroke. Anything below that would be heat exhaustion or heat cramps. So very, very important that we make sure that that's clear before we move on. Okay, moving on. Providers should never attempt a water rescue unless they have been properly trained to do so. Not much more to say there. Don't do something you don't have training to do. The next bullet point is the two special problems seen in scuba diving accidents are arterial gas emboli and decompression sickness. Really nothing more to say there. We did an entire section on that. And if you are not familiar, go back. You'll be able to go through that section one more time. Finally, when treating a scuba-related injury, EMTs should contact medical control to determine the most appropriate destination. That certainly is an appropriate thing to say, with addition to specific injuries related to spiders, scorpions, snakes, or any other insect that can get patients sick, because we may need to take them to a hospital that has a specialty care level available to take care of said patients. So at the end of the day, remember that things like scuba diving related injuries or envenomation, that's considered to a degree a specialty type call that might require specialty care services. All right, now as we kind of cruise through the rest of these slides, understand that these are not questions that I'm going to answer, but questions that you can consider when you're doing patient assessment. And if you'd like more, you can go ahead and comment below and I'll answer as soon as you go ahead and set that comment up. First questions to consider: is your scene safe from heat, cold, or venomous creatures? How can I get my patient out of the water safely? With regard to hypothermia, does the patient have an altered mental status? Because remember, if they are very cold to the touch and they're altered, that's a significant illness, significant injury. The same can be said about hyperthermia. If the patient's skin is cool or normal, we would probably consider that to be heat exhaustion. But if it's hot to the touch and they're altered, that is significant. Now that actually takes us all the way up to the critical thinking questions and then the disclosure slide. So I'm not going to continue from here, but I do want to say that this is absolutely an important chapter for you to practice with, and one that goes very well along with the actual chapter from the book. The book again is Emergency Care, 14th edition from Limmer, and it's published by Pearson. It is the big yellow book, which I can go ahead and hold up for you right here. This guy right here. So remember that it goes along very well with the chapter. It's chapter 35 in that book, as well as with the handout. This is not something that I would recommend anybody watch and say, yep, I'm an expert when it comes down to environmental emergencies, but it is a good way for you to get started. And if you're not an EMT student, I would always like to encourage you to find a local training center around you and take the EMT class in full, because these videos are not going to be a supplement for what it takes to become an EMT. Thank you very much. Have a great day. We'll see you next time here on the Band-Aid Man OC. Bye-bye.